Hi everyone, welcome back to Karlee's farm. Today we're going to talk about drugs and the kidneys, or medications in the kidney. There's a few different things that I want to cover. I guess one of the first things that I want to talk about is how we need to manage medications when the kidney is not functioning very well. So I'm going to talk about renal dose adjustment. And then what we're going to talk about as well, I hope you can see that okay. Then what we're also going to talk about is what effect some drugs might have on the kidneys to cause renal problems. And then finally, we are going to talk a little bit about what medications are needed in chronic kidney disease. So the first thing we're going to cover is renal dose adjustment. So this is where you might have a reduced renal function. And the way that we measure renal function is usually by glomerular filtration rate, or GFR. Now, there's a lot of different ways to measure GFR, and it's presented as units per time. So let's say mils per minute is pretty common. And what that essentially tells us is how it is a measure of creatinine clearance. So how much creatinine the kidney is clearing as a surrogate to its function. And so what we need to do when we're thinking about how to dose medications in reduced renal clearance is the first thing we need to do is really take a thorough history, particularly of what medications the patient is on. So if we recognise that the patient has reduced renal function, which we'll talk about in just a moment, but we need to understand, is this acute? So is this new, or is this chronic? And have they had it for a little while? So we need to take a proper history, try to work that out. We also need to take a history to understand what medications they're taking, because what we might need to do is we may need to alter the dose of some medications if they have renal clearance. So we take a nice history, understand what all of the medications they are on. Two, we may know, so what we do know, what we can get is a serum creatinine. So if we know our creatinine in serum, then we can calculate a GFR. There's a couple of different ways to do this. The most common way when we're talking about drug dosing is an equation called the Cockcroft-Gault equation. That's how a lot of medications have been designed to be adjusted using that equation. And there's another one that we use really commonly, which is called the MDRD equation. And it gives us, on our blood test results, the pathology will report what is an estimated glomerular filtration rate. And so we can also use this to work out what our renal function is. So once we know what medications we're on, once we've calculated our GFR, then our next step is, hope you can see this, is to make dose adjustments. Now, fortunately, there are some really reputable references that help us to do this. So if you have a patient who takes metformin, say for type 2 diabetes, we know we can go to a drug reference and it will say if your eGFR is between 30 and 50, then the maximum amount of metformin that's safe for those patients is X amount of milligrams per day. So we go to a reputable source and we can change or update or check the doses. And then most importantly, especially with any sort of acute renal dysfunction, is to monitor. And so I'm talking here about monitoring both the effect of the dose, so effect of the drug. So if we make a dose adjustment, monitoring whether it's effective enough, if there's any toxicity, but also monitoring the function of the kidney. So as things maybe start to improve, we might have an improvement in kidney function, or if things don't improve, they may actually get worse, then we may have a worsening of renal function, and so we may need to further dose adjust. So that step here about monitoring is really important. Now, there's just a few extra little things to note here that need to be taken into a consideration. So again, as I said before, we might have acute changes in our kidney function, or it may be a chronic. And patients may need dialysis, renal dialysis to support kidney function. Now, for patients who are on dialysis, this is less important. We don't have to worry about measuring the GFR if we know they're on dialysis, but we do have to make dose adjustments based on the dialysis. And there are different types of dialysis. So there's dialysis that you get 3 times a week. There's also acute dialysis that you can get sort of as continuous dialysis, particularly, say, in intensive care. So the type of dialysis matters. The time of dialysis matters. So do I get it 3 times a week? Do I get it all the time? Do I get it 16 hours a day in intensive care, for example? And then the other thing is there any residual renal function? So particularly in acute renal impairment, there can be some preserved renal function and some preserved urine output, and so we may still get some clearance of our drug through that. The mode of dialysis is very important because different modes of dialysis are able to clear drugs at a different rate, and a different proportion of drug is cleared. So the type of dialysis is really important to know. So that's really a quick overview of managing medications in renal impairment. So I might just pause us here and clear the board, and we'll go on to talk about sort of how drugs can cause or be involved in renal impairment. Okay, so now we're going to talk about, I guess, where drugs might be able to cause or be implicated in poor renal function. So essentially with renal impairment, there's usually 3 main causes that we sort of have to think about. It could be pre-renal, it can be intrarenal, and it could be post-renal. And medications can be involved in sort of all of these different sections. So pre-renal is really where there's a reduced perfusion to the kidney. So this can happen with things, say, that reduce blood volume, so things like diuretics, for example, that might reduce blood flow. This can happen with things that might constrict blood vessels around the kidney. So, for example, non-steroidal anti-inflammatory drugs vasoconstrict the afferent arteriole coming into the kidney. ACE inhibitors, they vasodilate the vessel, the efferent vessel on the outside, on the outflow of the kidney, and so they can reduce the pressure in the kidney, the blood pressure in the kidney, and so that can cause reduced perfusion. And then you're looking at things here as well, like dehydration, even things like reduced cardiac output, where there's a reduced blood flow to the kidney. So drugs that can reduce cardiac output might cause a pre-renal, might be implicated pre-renally. The second lot is intrarenal, and essentially there's a couple of different things that fit in here, but the 2 main ones where drugs are related is an acute interstitial nephritis, which is more or less an allergic process, and so it's very hard to predict. So any drug can be implicated here, really, some more likely than others. And then the other group is an acute tubular necrosis, which happens with our drugs that we kind of know to be nephrotoxic. So things here like aminoglycoside antibiotics, and the vancomycin antibiotic, etc. So these are more predictable in terms of their nephrotoxicity. And then the final group are the post-renal, and this is really obstructive. Sorry if you can hear that, that's the helicopter landing. So this is really obstructive, so when there's an obstruction to stop something getting out of the kidney. And this is where, things like renal stones, so any drugs that can precipitate calcium precipitation, increase things like that, uric acid, etc., can be implicated here, although they're much less common than these other sections. So that's sort of a quick overview of, I guess, where drugs can be implicated in renal impairment. And if you've got a patient with reduced renal function, then you need to sort of think about, are any of these, do we need to be thinking about any of these in the context of that renal function and the risk of additive effect. Okay, I'm going to pause this again, and we're going to come back and talk a little bit about chronic renal impairment and what sort of drugs we use to treat patients with chronic renal impairment. Okay, welcome back. We're going to talk really quickly now about chronic kidney disease, or CKD, and the drugs that we need the drugs that patients with CKD need to maintain their homeostasis. So what we need to think about here is, what do the kidneys normally do? And if I have an impairment in my renal function, what sort of functions are going to be impaired that I might need help with? So some of those things might be electrolyte abnormalities. So the kidneys obviously are very important in sodium and potassium, phosphate, calcium, homeostasis of the electrolytes. And so obviously if there's sodium, you also have water in transport affected too. And so these patients will quite often get fluid overload. And so we use diuretics for these patients. Usually you need really high doses. They're loop diuretics most commonly. Usually you need really high doses so that they can actually get to the part where they're working, because obviously there's an impairment leading up. And so we usually need quite high doses of loop diuretics. What happens so we get an increase in sodium and water. We also get an increase in potassium. There's less clearance. And so what we might need is drugs to reduce potassium. Hyperkalemia is a potentially fatal condition. And so patients with chronic kidney disease can be on maintenance therapy to keep their potassium low. So some patients, dialysis, for example, is used to get rid of potassium. But there's another medication that is used chronically to reduce potassium, and that's polystyrene. Bit crazy, polystyrene resin. There's a couple of different ones. But basically it binds the potassium in the tummy and prevents absorption. So you pass your potassium out of your gut. Can you see that? Probably running a bit off screen, sorry. If you have hyperkalemia acutely, there's a different management altogether, and that involves insulin as a general rule, plus dextrose to avoid low blood sugar, but insulin pushes potassium back into the cells. So it's a short-term acute management of hyperkalemia. This is going to move us down a little bit. You can also get phosphate accumulation, and there's a few different drugs that are used to prevent phosphate absorption. Again, the aim is to prevent GIT absorption. And we do this through calcium. So calcium binds to phosphate in the tummy and prevents it from being absorbed. There are other agents too, which can also essentially work the same way, bind to phosphate and prevent its absorption. Calcium which just intrinsically is linked to vitamin D, which is intrinsically linked to parathyroid. So there can be a mismatch, an upsetting of the calcium, vitamin D, parathyroid axis, and these patients just need to be really closely monitored and treated as appropriate. So if they might need, say, vitamin D supplementation to increase calcium, and the parathyroid and treating hyperparathyroidism, which can be related to CKD, is a really important part of maintaining that access. So this is basically monitored and treated as it's needed to be, essentially. The other electrolyte, I guess, or that can be accumulate in renal dysfunction is hydrogen or acid, and so patients may need bicarbonate administration to reduce or to balance out that additional hydrogen. And then finally, and I'm running out of room on my screen, but finally, might pop it up here. Patients can get anemia, and that is because there's a reduction in erythropoietin production, which happens in the kidneys. And so these patients will get erythropoietin, EPO supplementation to manage anemia of chronic kidney disease. So hopefully that's not been too overwhelming and gives you a quick sort of overview of some of the main issues that patients with CKD face and some of the drugs that you might see on patients who have chronic kidney disease. Thanks for joining me, and I'll see you next time.